iDocs, and let's go to the discussion, which is the end of at the end of each session. This is the rule. At the end of each session, we must solve the iDocs questions so that we can get the most benefit of the session. We can read everything in American Academy, and the added notes in Kansky, and the added photos of Kansky, and then at the end of each session, we will go for the discussion or the MCQ questions. By the way, this question came out in previous advanced exam. This question, which is regarding this corneal transplant, this is a case post-keratoplasty case, and you can see the ghost dendrite here. You can see the dendritic ulcer. This is herpetic keratitis or herpetic epithelial disease after penetrating keratoplasty. You can see that this is important, and this is the commonest cause. And you can be back to this slide. This slide or this photo taken from Kansky is mentioned before. So here it is the most common infective cause of corneal transplantation in higher economy countries. This is to be mentioned. This is true. You can exclude the all three. Number A, oral antiviral generally taken for 1 month after surgery. No, it is at least for 6 months or 1 year. Oral antivirals taken post-operatively have no effect in decreasing graft failure. This is extremely false, and this is against that of the herpetic eye disease study. The herpetic eye disease study recommended the use of oral antivirals to prevent the post-operative recurrence of the herpetic keratitis. Oral antivirals taken post-operatively have no effect in recurrence of the disease. This is also extremely false. So number D is the true answer. Let's go to this one from iDocs. Which statement is false regarding the treatment of recurrent herpetic epithelial keratitis? Which one is false? Topical antivirals may require up to 14 days to work. This is true. Debridement of active dendrite is typically of little value. Debridement is extremely important. Here, the debridement may be an alternative, but I can object on being alternative. It may be adjunctive therapy. It may be used in combination with that of the trifluridine. So in resistant cases, you may have debridement. So this one is false. Number C, oral acyclovir may play a role in the treatment. Yes, oral acyclovir may play a role in the treatment instead of that of the topical treatment. Topical steroids are contraindicated in active epithelial disease. Yes, to prevent the progression to the amoeboid or the geographical ulcer. How about this one? This is a case of papilloma, as you can see, eyelid papilloma. Which is involved here? Can you know this? A or B or C or D? A, HSV, herpes simplex. B, human papilloma virus. C, Steinbar virus. Yes, number B, human papilloma virus, HPV. This is obvious. Okay, so here let's go to this one, which is dendritic keratitis. As you can see, this is typical dendritic keratitis. 50-year-old lady present with 4-day history of redness and photophobia of the right eye. She had a similar episode 6 months ago. So this is a recurrent disease which resolved spontaneously. Appearances are as shown here in this photo, which is true. History of multiple sex partners may be relevant. No, here the herpes simplex virus type 1 is not sexual transmitted disease. Histopathology shows intracytoplasmic inclusions. No, it is intranuclear. There is a difference between the intracytoplasmic inclusions. By the way, the intracytoplasmic inclusions are found in cases of molluscum contagiosum. So the specimen of molluscum, which is like the eruptive volcano, with having here the inclusion bodies. These inclusions are intracytoplasmic, not intranuclear. Number C, treatment is necessary for resolution. No, the treatment may fasten or may speed up the resolution, but it is not that necessary. Edges of the lesion stain with rose bengal. So number D is frankly true. Number D is true here. The edges are stained with with rose bengal staining. By the way, this is the explanation. You can read the explanation. This is IDOC's explanation. I explained every phrase, so we don't have to repeat this again. All of the following features of corneal dendrites favor the diagnosis of herpes zoster ophthalmicus over herpes simplex virus, except, so you can look for the false answer. A large frequently branching dendrite. How about this one?
No, it's small, less branching.
Yes, small and less branching. Dendrite with no terminal bulb. This is true. A dendrite with an overlying plaque of epithelial cells or mucus plaque. This is also true. Dendrite with dull fluorescein and rose bengal. This is also true. So number A is the false one. So this will be the correct answer. Rounded gelatinous appearing lesions of the conjunctiva with vessels at the periphery but never with the nodular substance are called. How about this one? This is a pathology question. Gelatinous appearing lesion. This is to differentiate between follicles and papillae. Follicles are like this description: rounded gelatinous appearing lesions of the conjunctiva with vessels at the periphery but never with the nodular or the center. Here you have the appearance of papillae. This is papillae, which is epithelial finger-like projection with vascular core of connective tissue. Here you can see the vessels. But in cases of follicles, you can see that you have here the epithelium and you have in the adenoid layer lymphocytic aggregation. So this lymphocytic aggregation is called follicles with no central blood vessels, and it may be mature with having a central necrosis like that. And this area may have central necrosis. This means that the vessels are concentrated or are focused in the periphery and they are never in the center. So the answer will be follicle. Another one for differentiating the follicles from the papillae, focal lymphoid aggregates in the substantia propria or the connective tissue of the conjunctiva are otherwise known as conjunctival follicles. Again, this is follicles. This is the definition of follicles: adenoid hyperplasia or lymphocytic aggregation. This is the connective tissue or the substantia propria of the conjunctiva. 48-year-old woman presents with gradual right blurring of vision and ocular discomfort. On examination, the corneal stroma is hazy temporally. There are deep corneal vessels in the temporal quadrant and +1 cells of the anterior chamber. Here we are talking about herpetic keratouveitis, because here you have deciform keratitis. By the way, this is typical for deciform keratitis, and you have also some reaction here. So it is iridocyclitis associated with the deciform keratitis. There are punctate epithelial erosions visible with fluorescein. She complains the eye has never been the same since an ulcer a few years ago. What is the most appropriate initial treatment regime?
Yeah, it will be topical steroid with prophylactic antiviral.
Yes, so the answer is number D, topical or ocular acyclovir 5 times daily together with dexamethasone, which is corticosteroid. By the way, we prefer to use prednisolone over dexamethasone. And by the way, this is not the usual regime. By the way, here he answered it as being A. He preferred here oral, but according to the herpetic eye disease study, I can confirm that the treatment is usually by topical and topical corticosteroids and prophylactic antiviral, which is also topical according to the herpetic eye disease study. Okay. But here, if the case is iritis, is typically iritis, not deciform keratitis. This is deciform keratitis, by the way. But if it is typically iritis, we may favor the use of oral acyclovir even after being not statistically significant by the study.
Mm-hmm.
Okay, but here this case is for disform keratitis. The patient has here disform herpetic keratouveitis. The mainstay of treatment is topical steroid. Here in the herpetic eye disease study suggested a trend toward the beneficial effect of adding oral. No, here a beneficial effect in adding oral acyclovir in cases of iridocyclitis, treatment of HSV iridocyclitis, not a case of disciform or stromal keratitis. This is important to be mentioned here. I object on this answer. So it is topical and topical. Which one of the following is true regarding conjunctival intraepithelial neoplasia, CIN? It doesn't usually respond to topical treatment. How about this one? By the way, I mentioned this because I mentioned something like that while I'm talking. So number A is false. It doesn't usually respond to topical treatment, may respond. It is associated with HIV. How about this one? I mentioned this before. I mentioned that HIV is a risk factor for having the human papillomavirus, which HPV, which can cause intraepithelial neoplasia or CIN, which may progress to squamous cell carcinoma or OSSN, ocular surface squamous neoplasia. It is typically okay.
Mm-hmm.
Okay.
Yes.
So it is typically fixed to the underlying sclera. No, there is a risk of conversion to basal. No, to squamous cell carcinoma. Acute hemorrhagic conjunctivitis. This is mentioned, typically seen by bicornavirids or bicornaviruses, which are enteroviruses and coxsackie-viruses. They are here. This is acute hemorrhagic conjunctivitis. In this case, this is mentioned at the end of the session. We have no number here, but we have 24-year-old man. Here you can see this infiltrations, subepithelial infiltrations, which are typical to the epidemic keratoconjunctivitis of the adenoviruses. Here you can read the question, but let's go directly to the options of choices, which is false. Topical steroids typically provide significant symptomatic relief. Yes, this is true. The corneal lesions represent active viral replication. No, here the corneal lesion, yes, it is not active viral replication. The corneal lesion here, it is immune-mediated or immune-related reaction to the presence of the viral or to the infection of the keratocytes or the infected keratocytes. So this is not the virus. This is immune reaction related to the presence of the virus in the anterior stroma. 6 weeks earlier, he may have had a membranous conjunctivitis. Yes, this is true. Topical steroids can considerably increase the duration of the disease process. Yes, this is also true. Similar corneal findings can be seen in the absence of antecedent red eye. Yes, and this is called Thigeson keratopathy. This will be mentioned in another session, Thigeson, but this is the same like adenoviruses. This is an important differential diagnosis, but with a white eye, not a red eye. A patient has chronic relapsing follicular conjunctivitis over a period of 6 to 9 months, which is most likely, which is the most likely cause. How about this one? Chronic relapsing. Here, for any chronic conjunctivitis, chronic follicular conjunctivitis, it is molluscum contagiosum. Yes, molluscum contagiosum is a chronic disease. Here are the causes of chronic conjunctivitis. By the way, if we have follicular conjunctivitis, you may have acute or chronic diseases. For the acute, you have the viral conjunctivitis. All of viral, except for the molluscum contagiosum, are acute. Molluscum is chronic. And you have here for the acute, you have the acute chlamydia. acute chlamydia, which is adult inclusion conjunctivitis. Some books like iDocs consider, or some websites like iDocs consider it as being chronic, but it is actually, it is subacute. It is not acute, that acute. It is not that acute nor chronic. It is just subacute. So the adult inclusion conjunctivitis caused by chlamydia is another cause. You have also toxicity, can be chronic and can be acute. Okay, you can have something called acute trachoma, which is atypical, non-typical form. The trachoma is usually chronic, but the acute trachoma can occur in some tourists who visits us, who visit Egypt, which is endemic for trachoma. So it may occur to a person with non-endemic area who visit an endemic area. This can be acute. By the way, we can deal with trachoma because we are endemic for trachoma. So trachoma can cause chronic follicular conjunctivitis. Here it is trachoma, and here it is molluscum contagiosum. As I mentioned, toxicity may be acute, maybe chronic. You may have again a disease which is called the oculoglandular Perineum syndrome. Oculoglandular Perineum syndrome is synonymous to, it is a bacterial disease, by the way. It's synonymous to cat scratch disease, but it may atypically be caused by other factors like Epstein-Barr virus or Epstein-Barr virus, as I mentioned before. Also, you can find some case which is called folliculosis, and this is chronic. This is following tonsillitis or adenoid remote septic focus, which cause allergic reaction here in the form of follicular conjunctivitis. Or also for the acute follicular conjunctivitis, you can see it in something called contact biliary conjunctivitis. It is somehow of allergy to some perfumes or some drugs or some eye drops. This is called contact biliary conjunctivitis. So you have acute causes of follicular conjunctivitis and chronic causes. This will be repeated in another session, but it is mentioned here in the question, so I wanted to clarify it. Which culture media should be used in suspected mycobacterium infection? How about this one? By the way, this is repeated. This is mentioned. This was mentioned at the beginning of the session, and it is number A, Lovenstein, Jensen, medium. Yeah, yes, and the stain for the mycobacterium infection is Ziel-Nielsen or acid-fast stain. This is a table. This table is good. This is an important table for the culture media, and this is repeated. I mentioned another table like it at the beginning. Which is the most common cause of bilateral interstitial keratitis? I see here the congenital one. You may see the acquired syphilis or TB or Coogan. They may cause unilateral. So the typical or the most common cause of bilateral is congenital syphilis. All are causes of interstitial keratitis except for here the loa or the Luisis. This is not a cause of interstitial keratitis. By the way, brucella and leishmania are not mentioned in Kansky, are not mentioned again in American Academy, but they are mentioned here. So you can memorize that loa doesn't cause corneal inflammation. The ring-shaped corneal stromal infiltrates seen in herpes simplex keratitis is caused by what? The ring-shaped, which is the ring-shape is called the disform keratitis, and it is antigen antibody complex precipitation, type 3 hypersensitivity reaction, and this is the typical for disform keratitis. This ring, by the way, the ring-shaped corneal stromal infiltrate is called Weasley ring. So Weasley ring. This is type 3 hypersensitivity reaction, antigen antibody complex precipitation. A purely eyelid nodule with a central crater associated with inferior follicular conjunctivitis. Classic picture for molluscum contagiosum. We can see that it is umbilicated like that. It has a central crater like that. Number 74. sorry, a 74-year-old man present with left forehead vesicle that respect the vertical midline. Here we are talking about what? We're talking about varicella or shingles or the herpes zoster ophthalmicus. Before continuing, what is the most appropriate initial treatment? Oral acyclovir. But here we have uveitis as well. We have +1 cells, we have +1 flare, we have nothing, keratouveitis. So we can use oral acyclovir together with dexamethasone. So the answer is number D, oral acyclovir tablets together with dexamethasone 0.1%. Classic epidermic keratoconjunctivitis, EKC, typically caused by what? Adenoviruses. This is important one. Adenoviruses type 8 and type 19. 8 and 19 and 36. By the way, I memorize this as being 3, 4, 7, and 11. 3 plus 4 equals 7, and 4 equals 7 plus 11. This is to memorize this. This is how I memorize this stuff. And here for 8, 19, and 36, you can add 8 to 37, not 33, 36, 37. 8 to 19, it will be 27, and you can add 10, it will be 37. So this is how I memorize this. So the answer will be number B. Classic epidemic keratoconjunctivitis is adenoviruses type 8 and 19. 3 and 7, they are for pharyngoconjunctival fever. The last one, a patient with a history of corneal ulcer treated in another country 3 years ago, presents as shown in the image above. This one. This is the ring of the disform keratitis, which is false regarding this condition. The lowest effective dose of topical corticosteroids should be used. Yes, and this is to treat the stromal keratitis. Oral acyclovir will expedite recovery? No. Here, this is mentioned, yes, this is mentioned frankly in the HITS herpetic eye disease study. This is the false one. And this is answered correctly right now. This is answered correctly in IDOCS in this question. Peripheral lesions with mild inflammation and preserved visual acuity can be observed. Yes, this is the description of the disform keratitis. Topical antiviral should be used continuously with topical steroids, yes, to prevent the activation of the disease. So this is, or to cover, or to give a cover, or a coverage, or a prophylactic treatment to the corticosteroid use. These are all the IDOCS questions regarding this session, and this was a sample of our course. This will be like this manner. I explain everything in American Academy, add some notes from Kamsky and some photos from Kamsky, some photos from the web, and after that I can add and structure the questions of IDOCS, and most of the previous exam questions may be added again to the sessions. This will be the manner that I'll do in this course. So thank you very much.
Thank you.